Hi, thank you so much for joining us during such a busy week. I'm Dr. Samantha Hill. I'm a cardiac surgeon in downtown Toronto and president of the Ontario Medical Association. We represent more than 43,000 doctors and medical students across the province. Our members, Ontario's doctors, have been on the front line of the pandemic since the beginning, and they've seen firsthand the effects on our patients, our colleagues, and the hospitals, not to mention the community healthcare system as a whole. We've invited you to help answer the most commonly asked questions about the new COVID vaccine. And we're heartened by the innovation of researchers and the hard work from governments at all levels to bring the COVID-19 vaccine to Ontario. It's truly been a collaboration of research and science, of physicians and allied healthcare workers to get us to this point. And many are calling this point the beginning of the end. And it's true, we are finally moving forward. But we're here today to make sure that everyone realizes that the fight is not over. Tomorrow, your frontline healthcare workers in Ontario will get the first vaccines here in Toronto and in Ottawa. And actually, that happened today. And while this is a huge step forward, it's only one of the many steps that we have yet to take. And it's critical that we all understand that this big step does not mean immediate protection for everyone. So that's why we're offering this technical briefing today. We are asking for your help to make sure that Ontarians understand the importance of this vaccine, encourage as many patients as possible to get it, and ensure that they understand what the vaccine is and is not. Like you, we look at the data. We review all of the best information available with a critical eye, keeping the best intentions and health outcomes for patients first and foremost. We look forward to sharing with you today the top questions our experts are getting from their patients. And we also look forward to hearing your questions. Please do note this briefing is being recorded and we will be sharing it later through social media. I'd like to now take a minute to introduce our doctors who will be covering the top 10 questions their patients are asking, and then we'll turn it over to you to ask some questions. First and foremost, I'd like to introduce Dr. Zainab Abdurrahman, pediatric and adult allergist and a pediatric immunologist in Mississauga. Secondly, I'd like to introduce Dr. Zain Chagla, infectious disease physician at St. Joseph's Healthcare in Hamilton. Thirdly, I'd like to introduce Dr. Isaac Bogoch, infectious disease consultant and general internist at Toronto General Hospital, which is part of the UHN. Fourthly, we're joined by Dr. Mariam Hanna, pediatric allergist in Burlington. And last, but certainly not least, we're joined by Dr. Vinita Dubey, Associate Medical Officer of Health for Toronto Public Health. And with that, I'll turn us over to the first of the 10 or 11 questions that we have that are most commonly being asked. Apologies, a bit of a technical detail. I was expecting to see it pop up on my screen. There we go. So the first question that we're asking, and this will go out to Dr. Zain Chagla, who will get the vaccine first?
Thanks, Dr. Hill. And today is a really monumentous day as we are starting to see who's getting the vaccine first, and lots of pictures from Toronto of some brave PSWs from long-term care who were the first to get their needles in the arm. So the federal framework really identifies 4 major groups that are getting the vaccine first: long-term care workers, long-term and essential caregivers, long-term care residents, those over a particular age, 80, then going down to 70, and healthcare workers, as well as those from Indigenous reserves. So we are prioritizing that as the days come, and again, part of that is due to the logistics on the ground, but the hope is all of these groups get the first batch of vaccines up till March, and then it starts seeping out to the general population after that.
Thanks so much for that great answer. We will move on to our second question, which is where will we go to get the vaccine and when is it our turn? Dr. Isaac Bogoch, will you take this?
Oh, there we go. Yes, I will. Thank you, Dr. Hill. So the vaccine is going to be distributed initially at a couple of centers. We know that there's 2 centers now in the province that are distributing the vaccine, but that's going to expand to probably 13 other centers within the province. And of course, we're using that system now to distribute the vaccine. We have access to the Pfizer vaccine. We know this Pfizer vaccine doesn't travel that well. That's why, at least up front, we're going to bring people to the centers rather than bring the vaccine to people. So initially it'll be in a few centers, but it will grow to other centers throughout the province as we have access to more and more vaccine. Interestingly, Health Canada is likely to approve another vaccine in the very near future, the Moderna vaccine. We know that's a much more stable product, and that's a product that can be moved around a lot easier. So when we have access to that vaccine, I think we can start to see vaccine programs roll out in the communities themselves and in, for example, long-term care facilities, and it can be brought to more rural, remote, and underserviced locations, for example, Indigenous communities that are, for example, fly-in communities in parts of Ontario.
Great, thank you. I know that everyone is really waiting for their turn to get the vaccine, and people are very excited about this. And so it's an important answer to realize that while not everyone has access to it today, those days are coming. Dr. Chagla, we're going to turn the next question to you again. Why do we need 2 shots, and when can we consider ourselves protected?
So answering the second part of this first, we saw some of the data from the Pfizer publication, which is actually now in the New England Journal, where we start seeing protection actually show up in the first 10 to 14 days. Now, that doesn't mean that we need 1 shot. It just means that that level of immune response is starting to happen 10 to 14 days after the vaccine and gets better and better and better with time. We do need the 2 shots because, you know, this is still a vaccine that's built on this 2-dose series, where when they did the phase 1 trials, they found the best dose optimization to get the best response was those 2 shots 21 days apart. And so knowing the seriousness of this vaccine, knowing what it does for our society, knowing that it is going to be used to reduce death and disability and hospitalization due to COVID-19, I think we have a due diligence to make sure that we do the series correctly and get the optimal amount of immunity in the population rather than half the series.
Absolutely, that makes a lot of sense. Thank you. Dr. Abdurrahman, people are asking, what will I feel after the vaccine? What are the side effects? And so I think this harkens a little bit to the flu vaccine, where lots of people feel very unwell after it. Many don't have any side effects at all. Can you tell us a little bit about how people will feel after the COVID vaccine?
So as with any vaccine, you're going to start to experience some symptoms, which might make you think about what it's like to actually have the illness, because the way a vaccine works is that we're giving you little bits of a pathogen in hopes that your body thinks it's getting infected, so it makes an immune response and then makes memory. So the next time you are exposed to it, you have this ability to generate these antibodies to tackle the infection. So your body also goes through the natural steps. It goes to when it actually is fighting infection. So you're going to notice, for some people, they might notice elevated temperature. That's a natural immune response to actually try to kill viruses. You'll also notice that you'll be feeling aches and pains, and that's just generally because you're feeling a little bit under the weather, because your body's kind of telling you to tamper down a little bit. Let's focus our energy on fighting this infection. You'll also notice localized redness, pain, some swelling at the site. And those are all actually signs of your innate immune response. So these are actually just signs of your immune system working. So you can expect to feel that, similar to how people feel it with the influenza vaccine, similar to how you might feel it with any of the other vaccines you get. And when I reviewed the side effect profile, it's very similar to many of our vaccines. You might notice a little bit more pain, tenderness than the influenza shot, but it's actually less reactive than the Shingrix. So just to give you an example, if you've had either of those 2 vaccines, it's kind of between the 2. But generally, there's going to be a lot of people who don't feel too much as well, who kind of just get their jab and are just going on their way. But these are the common things. And the common side effects really are feeling a little bit under the weather, maybe some elevated temperature, aches, pains, localized swelling, and pain. And those would be the common side effects to expect with this.
Thanks so much for that great explanation. So it sounds like you're telling the audience that often what we feel when we feel unwell is actually just our immune response kicking in. And so feeling sick after you get a flu vaccine or a COVID vaccine or Shingrix vaccine is not about the actual illness, but about your body trying to fight it.
Exactly. That's how your immune response actually starts the response to the infection. So you associate it with getting sick because that's some of the times that you commonly see this response happening, but that's actually also what we want. So you can make the antibodies that you need to remain protected against these different pathogens, in this case, the COVID-19 virus.
Excellent. Well, none of that sounds as bad as having COVID.
No, not at all.
Moving on to the next question, which is also for you, Dr. Abdurrahman. I've heard that people who have experienced anaphylaxis or allergies should not take the vaccine. Who else should not take the vaccine?
So with the rollout in the UK, initially they had 2 cases where they had noticed anaphylaxis-like reactions, and those patients were treated with epinephrine and they recovered quickly. With that, the public health team in the UK had opted to initially be a little bit conservative while they were still investigating this, and initially put out a statement to that effect. But with review of all the information, all the data, looking at those in the studies, there was actually no increased risk of having anaphylaxis in this vaccine compared to others. It's important for everyone to know that people who had food allergies and had other allergies were included in the study. There were some, I've seen some questions if they were included, and they were. The only people who were excluded were people who have known allergies to components in the vaccine. So with reviewing all this information, both the FDA south of us, as well as Health Canada, have made the recommendation that the only people who should avoid this are those who've had anaphylaxis to a first dose, knowing this is a 2-dose regime, or if you are known to have anaphylaxis or allergy to one of the components. Similarly, the Canadian Society of Allergy and Clinical Immunology is also releasing a statement to that effect, letting patients know that if you have a history of anaphylaxis to foods or venoms or kind of routine medications like penicillin, you do not have to avoid this medication. The component that seems to perhaps be maybe driving some of the reactions is actually polyethylene glycol, and that's at least what's hypothesized, as that's one of the components of the vaccine that can induce allergic reactions. But this is actually a very rare allergy, and if you had this allergy, you're well known to an allergist by this point. It's polyethylene glycol is actually in a lot of medications, which we use routinely, most commonly being Tylenol. It's in both the liquid form that we give to young children, as well as the tablet forms. So if you've ever used that medication without an issue, you know that you don't have an issue with polyethylene glycol. So from our standpoint, for patients without this, we don't have to worry in terms of the concerns when it comes to the reactions, and that is not a contraindication, okay? In terms of other special populations that sometimes come up in terms of who should and should not get the vaccine, we often worry about patients who are pregnant, so any pregnant persons or immunocompromised individuals are also some special populations that we're often concerned about with any kind of vaccine. Specifically, we're often concerned about live vaccines in these patients because there's a risk with a live vaccine that you could actually develop symptoms and have a milder form of the infection. And for someone who's immunocompromised, this could lead to quite a serious infection, even though it's a vaccine strain infection. This vaccine is not live, so does not have that increased risk. It was not specifically studied in these 2 populations, though, those pregnant persons or immunocompromised persons, but based on the immune concerns, there's not an immune concern from the fact that it's not live. So with this, currently at this time, the CDC has just stated that these patients would be eligible to have the vaccine, but should just have a really informed consent process. So really speak to your doctor in terms of your risk. And so this is going to really be rolled out as we talked about the people who are getting it first. If there's someone in those groups who happens to be pregnant or happens to have some form of immunocompromise, they're really going to need to just have a discussion with the administering physician and then make a decision if they wish to proceed because they are at higher risk, or if they prefer to perhaps wait until secondary rollouts, but that's going to be an informed discussion that needs to happen at that time. So at this point, really the people who need to avoid this are those who have a prior anaphylaxis to a prior dose, or who are known to have anaphylaxis or allergy to one of the components, namely polyethylene glycol.
It's great to hear that there are so few absolute contraindications to it. The people who are immunocompromised, obviously every vaccine comes with informed consent, but they're also going to be some of the most, the people who will most benefit from getting a vaccine. And so it's really good to know that the only real absolute contraindications, as you said, are an allergy to polyethylene glycol or some other constituent in the vaccine, or an anaphylactic allergy to the first dose. And I know that there are people listening who will be a little bit shaken by the term polyethylene glycol. It sounds big and scary. And as you said, it's in lots of different things. You've already been exposed. And it's just a reminder that when you start reading the labels of anything, whether it's a can of soda or your medications, there's lots of scary terms out there.
Absolutely.
Excellent. On to the next question. This is for you, Dr. Vinita Dubey. Can you tell us how the vaccine works and what do we actually know about this new technology?
Well, it's really great vaccine, and it works in a different way as well. So the vaccine actually tells your body to make a spike protein. And we know that this spike protein is specific to the virus that causes COVID. And so your immune system will respond to the spike proteins, and they will make antibodies, and the antibodies will in turn fight off infection. And so now your body has made all of these antibodies, which will then break down the spike protein and the vaccine actually, but you're left with the antibodies. And so the antibodies that you're left with will then protect you if you're exposed to COVID and keep you from getting sick. Now, we know that this kind of vaccine, a messenger RNA vaccine, while it's new for COVID and for general vaccines, they have been used for other types of cancers. It's not brand new technology. It's just being used now for the first time with this vaccine.
I've said a few times that this is what living on the leading edge of science looks like. COVID has been an opportunity for us all to experience that, and it's not always comfortable. Can we go back to that piece about the spike protein? I'm not sure everyone else in the audience will know what that means. Can you explain what a spike protein is?
Yeah, so the spike protein is a piece of the COVID virus that the virus needs in order to infect you. And so it's actually just a piece of protein that your body attacks, makes antibodies against, but it's not the whole virus. And so that's why the virus can't give you COVID, but it gives you enough to make your body think that it's infected, develop antibodies against that particular protein, and then you're protected.
Excellent. So it basically tricks your body into thinking that you have this infection, recognizing it based on this protein that it's been formed to create, like I would recognize someone by a red shirt, and then goes off to attack it if it ever sees that person. Hopefully I'm not seeing anyone wearing a red shirt.
Exactly.
Thanks so much for that. Our next question is going to go off to Dr. Bogoch. Dr. Bogoch, how long will this vaccine protect us? Will we need to get it annually, like the flu shot? And can you talk to us a little bit about how the COVID-19 vaccine is actually different from the flu shot?
Oh, those are great questions. So the question is, how long will this vaccine protect us? We don't actually know the answer to that just yet. I mean, we've only started using this particular product in humans since March, when the first phase 1 clinical trials begun. So we don't actually know how long protection will last. And clearly this is something that is going to be studied formally with time to see if perhaps people do need booster vaccines. So that sort of leads to the next question. Will we need to get it annually like the flu shot? Again, not quite clear just yet, but we'll have a much better understanding with time. And as more and more people get vaccinated, and as we have more highway miles under our belt, we'll have a better understanding of whether or not people need to have booster vaccines and what frequency they may need to have booster vaccines. This vaccine is very different from the flu vaccine. And Dr. Dubey just outlined how this vaccine works. I think we should remember that the flu vaccines that we're getting are what are called live attenuated vaccines. They're basically made from weakened influenza viruses. This is not a live attenuated virus for COVID-19. This is not even a virus. This is mRNA. And as Dr. Dubey pointed out, this basically tricks our body to make a little component of the virus, and it tricks our body to making that component so our immune system recognizes it and mounts a response to it. So this is not a live attenuated virus. This is not used from a weakened coronavirus. This is a completely different mechanism of mounting an immune response. And this is through an mRNA technology, which is absolutely brilliant. It looks like it's a very successful way to do things.
It is. It's been absolutely brilliant to watch it happen. I'm sure you'd agree.
Oh, yeah.
Dr. Hanna, the next question is for you. And this is the question I think everyone really wants the answer to. It's a short question, but it's a big one. Is the COVID-19 vaccine safe?
It's a great question. I think it's a pretty loaded question to answer. So vaccine safety, if we take a step back, is heavily scrutinized in any vaccines that we have on the market. Vaccine safety is first established in clinical trials, but the part that people often overlook is that vaccine safety is also looked at when it gets into real world data. So let's take a step into this COVID vaccine that we currently have, the Pfizer vaccine. The clinical trials were powered to look for even rare side effects. 44,000 doses of vaccine already administered, not counting the stuff that's been going on over the past week in the UK, and now as we get it into the real world. We recognize that there are incidents of certain reactions, like my colleague was mentioning. So Dr. Abdurrahman nicely mentioned to you guys, local reactions, pain, bit of redness, bit of swelling. These are things we can expect with any vaccination. They may occur a little bit more often or a little bit less often with this vaccine, just as you compare it to others. Systemic reactions like fever, not feeling well, or having a bit of a headache. Again, they can occur more with the second dose potentially, but these are very, very mild side effects when we compare them to what the actual disease looks like and are easily addressed with antipyretics like Tylenol or Advil or pain medication should that be required. So then what happens with vaccine safety monitoring? So this happens on a local, provincial, national level, and what you guys have seen also on an international level. This happens with any vaccine that we have our hands on. And the best example of it actually happened last week. So let's not dig too far back, when 2 cases in healthcare workers of an adverse reaction occurring fairly quickly after administration resulted in us looking back and saying, is there a safety signal that was missed in the clinical trial data? Is there need to further evaluate these patients or these cases to see what is it that occurred? And is there need for modification in our recommendations, or are the recommendations still safe? And this is what vaccine safety is all about. We know it's safe. We continue to gather data to ensure that it's safe. And this is kind of the real world data is probably the most exciting part to look at as vaccines get implemented, so that when it's your turn to get the vaccine, the safety data is not only 44,000 patients, it's in the millions by that point.
It's an amazing point. So not only is there extensive testing that happens before it's rolled out to market, but once it's rolled out to market, there's ongoing testing and looking at the data and looking at the reactions to make sure that we don't find something new. That really is the leading edge of science, isn't it?
It is. That's where we hang out, cutting edge.
The next question's for you as well, Dr. Hanna. So children aren't eligible for this vaccine. Can you tell us why not, and how we're going to achieve herd immunity if we can't vaccinate children for another year? We've seen all of the asymptomatic spread that's happening in schools, and we know how worried people are about this. Can you shed any light?
Yeah, absolutely. So just to reiterate, the currently available vaccine is approved in 16 and up. We do have clinical trials underway in pediatrics, and this isn't uncommon. So current clinical trials in 12 to 15 are underway, and even for those under 12. As is the process with many vaccines as they are developed, their first established safety is in adults, and then we start looking at pediatric trials. We don't just extrapolate the data to pediatrics. A person's immune system actually matures in very different ways from infancy through childhood, adolescence, into their adult years. I hate this statement because it's a cliche, but let's say it. Kids are not little adults. Truly, their immune system is not that of a little adult. So a child's immune system behaves a little bit differently throughout their childhood. And that's why we start looking at different age groups when we extrapolate, first of all, safety, like I mentioned in the last slide, or the last question, sorry, but secondly, efficacy. Initial vaccines, you know, when we give them to babies, sometimes we require a bit more boosters. So for example, a child getting their tetanus shot, they cluster their shots a little bit more together and then they become more spaced out into their adult years. Will this be the case of the COVID vaccine? Data and time and efficacy will show us that. So without clinical trials in pediatrics, we don't just extrapolate to them. We await the results of these trials, and they're coming. They're already well underway in warp speed type fashion. So children make up 20% of our Canadian population. So are we going to achieve herd immunity by ignoring them? Absolutely not. During the course of this pandemic, we recognize that in pediatrics, thankfully, most of the cases have been in general milder, but they are able to still carry the disease and transmit the disease. So it's definitely foreseeable to get full control. We need to have immunity in children, but we need safety data, efficacy data, and that is coming. So first and foremost, we need to continue to keep our guard up during this transition time. Kids are not included in the phase 1 rollout, maybe in phase 2, but probably phase 3 will definitely include kids. So until then, we refer to the 3 guards that we have of physical distancing, masks, and hand hygiene, but COVID vaccine for those that can get them. Let's not forget that.
That's such an amazing answer. And I'm glad you said that children aren't just small adults, because if you hadn't said it, I would have had to. So I'm glad it came.
I hate that one.
It's such a good cliche, though. I do want to ask you just a follow-up to that, because there's a little bit of a gap there between us saying children aren't eligible, but Dr. Abdurrahman told us that the only absolute contraindication was in allergy or previous anaphylactic reaction. Can you just extrapolate on that a little bit for people who aren't aware of the subtlety and the difference there?
Yes, so the current age indication still holds 16 and up. In the 16 and up age group, the only absolute contraindication is reaction to your first dose or reaction or known allergy to one of the components of the vaccine.
Perfect. And I expect that as we get that data that you were talking about soon, we'll change the age guidelines, but those absolute contraindications will remain the same.
I suspect so as well.
We'll see. Dr. Dubey, this next question is for you. And this is another really good question that I think everyone's been asking for at least 7 months now, so you should be used to answering it. But how soon after getting the vaccines can we return to life before COVID-19? How soon can we stop wearing masks? Can we start traveling? What do I need to do after I get the vaccine? Do I still have to wear a mask? Do I still need to stay home, etc.?
Yes, 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 and yes. That's the short answer. I had a slide with a graph, if we could just pull that up. There's no question that we have big hopes for this vaccine, and based on the early trials, we can see that the vaccine has very high efficacy, which is going to bode well for us. But I thought this was an interesting slide to show with polio. A lot of people actually may remember polio and how it impacted their summers. And you can see here in this slide from the Public Health Agency of Canada that in the 1950s, polio vaccine came about, and by 1962 we had the oral polio vaccine. And so while we continue to have spikes of polio cases, eventually we had a dramatic decline. And I think the point here is that you can certainly get a dramatic decline from vaccines, but it still takes time. It's not overnight. It still can take months or even years. And I think part of that is because we have to get everyone vaccinated, and that's going to take time as well. So in the meanwhile, we're going to wear our mask and physical distance, stay home if we're sick. If we're sending our kids to school, we're going to screen them before we send them to school. We're going to do all of these things that are not only working to prevent COVID, actually our influenza rates are extremely low this time of the year. We've never quite seen that for a long time. So we're going to keep doing all of those good things to keep COVID at bay. Especially we want to protect the vulnerable, the long-term care homes, those who are living in a shelter, those who may get more serious consequences should they get COVID, like our grandparents and those who are older in our population. And we're going to give a chance for everyone to get vaccinated, and we're going to wait to see the results of the vaccine. And we're going to hope that the vaccine is going to look like polio, measles, a lot of these viruses that were very prevalent in Canada not too many decades ago and have subsequently declined.
Great answer. Absolutely. Thank you so much. So our last question, I think everyone's going to take a chance to answer this, but we'll start with Dr. Bogoch. So Dr. Bogoch, should I get the vaccine?
Yes. Short answer is yes, you should. There's going to be very few reasons to not get this vaccine. It's pretty clear how devastating this infection is and what it's done to Canada and the rest of the world. It's pretty clear that there's potential for long-term effects from infection. We've seen what it can do to healthcare systems. We see how it can spread like wildfire through communities. And we've also seen this incredible data that demonstrates a safe and what appears to be a rather effective vaccine. So should I get the vaccine? Absolutely. The second it's my turn, I'm going to get the vaccine.
Awesome. So let's go through the panel one by one. Will you be getting the vaccine? Dr. Abdurrahman?
Absolutely, yes. So similar to what Dr. Bogoch has said, there's been great evidence for the use of this vaccine, and we know the effects of this virus. And so I would suggest to everybody, when it is your turn, I urge you strongly to get this vaccine. Protect yourself, protect your loved ones, and protect your fellow humans. This is what we've been waiting for, and this is how we're going to get ahead of this pandemic. So I will definitely be in line when it's my turn, and I hope you will be too.
Such a great answer. Dr. Chagla?
Yeah, so I think when my ticket's called, I'm going to be very happy to get the vaccine. I think it's an incredible story of progress and again living on the edge of scientific reality to be able to apply the vaccine in a box model and actually have it ready within a year of reading about this infection is just astounding. And I'll say to people, I've worked in clinical trials and tried to work through regulatory processes. It is incredibly strict and incredibly hard to do these types of studies. And so I have the utmost reassurance of what's come out with these clinical trials, from the review from Health Canada, the FDA, the UK Medicines Administration, that this vaccine has surpassed the bar for safety here, knowing what rigorous processes it has to get to this point.
Absolutely. Dr. Dubey, what about you?
Yes, get the vaccine. If you can get the vaccine, you have no contraindications, absolutely. I think it's amazing to think that we all know, we've all suffered from COVID. COVID has impacted all of our lives, whether we've gotten it, whether we've seen people that have had it, whether we've had to take our own precautions and modify our life. We have all been impacted by this. And we have a light at the end of the tunnel. It really is a vaccine that will get us out of this. And it really is, a lot of us don't understand what it was like living with all kinds of infectious diseases. And when a vaccine came around, it turned things around. And we can see actually the impacts of the hope for this vaccine. And I work in vaccines, usually from a public health side, and often say the vaccine is one of the best medical interventions that we have overall. And I think it's bearing to light. I think we can all see this. I think the one thing that I would say is if you have questions, if you're hesitant, please do ask a trusted source. And we know with vaccine hesitancy that there's a lot of misinformation out there for vaccines in general. If you've heard things about this vaccine that are negative, it may be misinformation. And so, because we just don't know a lot about the vaccine to date. And so really, I would say, if you have questions, get them answered, but get them answered from a trusted source so that you feel comfortable and confident. No one's going to force you to get vaccinated. It will be by informed consent that you get vaccinated, but it will be a good choice for you and for others as well.
Thanks so much. I'm going to expand on that a little bit and say that a trusted source is generally your family doctor or your specialist, someone you know and have a relationship with. It's not Aunt Mary, Uncle Google, or your Twitter account. Dr. Hanna, are you going to get the COVID vaccine?
Oh, when it's my turn, I will certainly get the COVID vaccine. But the big question is, will my patients? And I can't wait to help them make that decision. I think it's a team project. Really, the development has shown us collaboration amongst healthcare professionals. And now it's time to collaborate as a community, because we can crush this curve, but we can bring it all the way down to zero like that polio curve. I love looking at it. It gives me promise as to what vaccination can do and what the future can look like.
So true. And so for me as well, you know, as soon as it's my turn, I'll be in line to get that vaccine. I am genuinely relieved that we didn't have to wait as many we have access to. The fact that our science and our scientists have been able to get this safely rolled out in less than a year is nothing short of a modern day miracle as far as I'm concerned. And I am excited to sign up, get my vaccine, have everyone around me get their vaccines, and maybe, just maybe, be able to hug a friend again. I missed that. With that, I will turn it over to Max, who will take questions from the media. Max, are you there?
Great, yes. Hi, everyone. Thank you so much for that great presentation. As Dr. Hill's shared, any questions in the Q&A document, in the Q&A chat, I will field and bring them to the doctors. The first is from Jenny Yoon at Toronto Sun. And I think we'll start with Dr. Bogoch on his answer for this one. Do you believe, given the composition of the vaccine trial participants, that the vaccine currently being deployed will protect the demographic of individuals in Ontario who are actually dying of COVID-19?
Yeah, that's a terrific question. And I certainly think it can. Now, of course, we know the composition of a clinical trial isn't exactly reflective of every population, but this composition, the composition of this clinical trial is reasonable, I would say. And actually, if we look in the crystal ball, just to expand that question and look ahead, what's next for Canada, which is the Moderna vaccine, which is probably coming through the pipeline shortly, which uses a very similar technique. They actually stopped or slowed down enrollment in their clinical trial so that they could enroll a greater diversity of patients or participants, pardon me, to really ensure it was reflective of the community at large. So at the end of the day, and that one, showed very, very similar results to the Pfizer vaccine. So I think at the end of the day, we're going to see some significant protection in the general community with these vaccines. But you raise an excellent point, because we have to talk about two things. One is vaccine efficacy, and then vaccine effectiveness. Efficacy is how it works in a clinical trial under ideal clinical trial settings. Effectiveness is what happens in the real world. And, you know, we have to expect some people might not come back for their second dose. Some people are going to be immunocompromised, where we know that they weren't enrolled in the trial. Some people are going to be at the significantly older end of the spectrum, for example, in long-term care, and have a lot of comorbidities that weren't necessarily accounted for in the trial. So, you know, is the vaccine going to work? Yeah, it probably will, but I don't think we should expect, just like any drug or vaccine trial, that it's going to be exactly like it worked in the trial in a real world scenario. But if it even comes anywhere close to how it performed in the clinical trial, we'll be doing some tremendous good. That's a really important question. I thank you for asking it.
Thanks, Dr. Bogoch. And building on that question, I'm going to stay on you for a second, and other doctors, please add where you see fit. From Cassandra at Canadian Press, what does 95% efficacy mean in practical terms? Some may think that vaccinating 100 people means 95 would not be infected.
Okay, so a couple of points with that. So let's just talk about exactly what that means. So they basically, I'm not going to use the real numbers because they're odd numbers and not even numbers. So let's just say they vaccinated 10,000 people, and they didn't. They vaccinated 43,000 people, and then of those 10,000 people, half of them got the vaccine. So sorry, let me rewind. I started off on the wrong foot. Let's say you got 10,000 people. Half of them get a vaccine, half of them don't get a vaccine. And you're following these people forward, okay? No one knows who got what. These are blinded. So half these people have a vaccine, half these people don't have a vaccine. You follow everybody forward through time. Throughout the course of this, of the time you're following people, you get 100 COVID-19 infections. Okay, you still have a big group of people. You still have 10,000 people, but there's 100 infections with COVID-19 throughout that period of time. And then you take a look and see, okay, well, who got COVID-19? And you find out that 95 of those 100 cases were in people that had the placebo, and only 5 cases were in people that had the vaccine. So that's what they're talking about when they're referring to vaccine efficacy. And it's just important to know. Now, of course, I think it's just like in medicine, medicine is no different from the real world. Nothing is 100 or 0%, right? People can get the vaccine and still get COVID-19. That's pretty clear. What's really interesting is when we look at the data from the Pfizer trial and also data from the Moderna trial, I got to be careful with my words here. I don't want to overstate data, but it might be the case where if you do get COVID-19 but have had the vaccine, you might have less severe illness. And that would be incredible as well. So A, it'll likely prevent you or strongly prevent you from getting the infection. And B, if you're unlucky enough to get the infection but still have the vaccine, you're less likely to have a severe illness. So that's a winner in my books, even if you're not preventing the infection completely. If you're keeping people out of hospital and keeping them out of the ICU, we're doing something good there too.
Thanks so much. We're going to move to the next question from Radia Chowdhury at Chatelaine. This will be to Dr. Dubey to start. While people start getting the vaccine, how cautious should we remain as Canadians from traveling elsewhere regionally to the US or overseas? Should we be paying attention to how the folks in the countries who are planning on traveling are being vaccinated and their rates?
Yeah, I think what we need to consider is the vaccine is one thing. We've talked about keeping those public health precautions, but all of our other tools for stopping COVID are also going to be important. So testing, there may be still testing requirements when we travel, case and contact follow-up, having the COVID-19 app downloaded on your phone. So if you're in touch with someone in close contact who had COVID, you will be notified. I think what we have to recognize is something like traveling is considered higher risk because you're more likely to have close contact with other people. And when you travel, you go on vacation, you're more likely to do things that can encourage the spread of COVID. And so just because we are vaccinated when we travel doesn't necessarily mean that we're fully protected through those travels. And so I think we're going to have to consider the whole gamut of what we're doing right now to prevent COVID with the precautions, with the testing, with the public health measures, and reducing our spread as much as possible. And that includes traveling even in Toronto, like, in Ontario, traveling from high regions to low regions of COVID activity within Canada and internationally as well.
Thanks so much. Next question is from May Warren at the Toronto Star. This is for Dr. Hanna. You mentioned critical clinical trials for children when answering questions in the presentation. When and where are those happening? And when might Canadian kids think they'll be able to see the vaccine once it's approved? In the meantime, would it make sense to prioritize workers like teachers, daycare staff, and parents who are around kids, especially to protect immunocompromised children?
Okay, couple questions to answer in that one. So let's start off with the initial Pfizer clinical trial did have enrollment of enough children between that 16 to 18 age group that they are part of the age indication. There were several kids that were between the age of 12 to 15, but again, not enough safety and efficacy data to put that as part of their indication. And the next part of their trial was looking at safety as well as efficacy in that age group. I believe now we're in phase 3 of the age 12 to 15 with younger age demographics, so 6 to 12 currently underway. I'll defer to my colleagues to tell us kind of the exact ones that are currently underway, but Pfizer I'm sure about, and then other ones I'm sure are in the pipelines as well. These clinical trials are done internationally, so not only are they considered in Canada, but there are other trial sites, not dissimilar to what was seen with the Pfizer vaccine. If I can make kind of a brief comment before I pass it on to my colleagues, the prioritization as to who gets the COVID vaccine first or not is part medical, part made by higher levels than us at this table. While I appreciate that there are certain exposures that different levels of workers or employees or staff people get, the current prioritization looks at those that are frequently exposed to COVID and have a very high risk of having morbidity and mortality associated with COVID infection. And as the availability of the vaccine increases, the availability of who gets that vaccine will also expand, and that prioritization will likely change over time. I was going to pass it on to my colleagues to ask or to follow up on the rest of that.
That's perfect. Thanks so much. So the next question is touching on a part of the presentation from Dr. Abdurrahman. I wanted to know more about the flu vaccine versus the COVID vaccine. Are there more or less side effects? I saw a chart that that was earlier on screen that we'll put up for you to reference.
Okay, great. So while that chart is getting pulled up, so each of the flu vaccines, we actually have a number of them. I had picked out the Fluvaval Tetra as it's one of the commonly given ones in Ontario at this time, just to show you in terms of the side effect profile compared to this COVID-19 one. And what you might notice is there's a bit more of the local symptoms in the arm with the COVID-19 vaccine. So this, it's a bit of a busy slide, I apologize, but the first column looks at that Fluvaval Tetra. And then here I am looking at the different populations in the COVID-19 trial, namely looking at the 18 to 55 and then the 56 and over, as well as the placebo group, which I used the 18 to 55 placebo group. And what you'll notice is there is a bit more of the local symptoms with the COVID-19 vaccine. So a little bit more pain in the 70 to 80% compared to 60% with the flu vaccine. Although one thing that we do notice is those who are above 55 actually seem to have a bit less reactivity. So perhaps, you know, thinking about our immune system, we often think about children and adults, but we actually know that when you actually go into the later stage of life, your immune system is still also changing. So sometimes you might see some of the less of the initial symptoms of pain, redness, because the innate immune system is not perhaps as active as we get much older. So with this, you'll expect to see, I think, similar rates of myalgias, which are just muscle aches, somewhere in the kind of 20 to 30% in the case of 18 to 55 with the COVID vaccine compared to 26 with the flu shot. And you'll kind of see with headache and fatigue, there's a bit more with the COVID vaccine looking at the 18 to 55, but then, you know, it's still a bit less when you get a little bit older. And if I wanted to add another column, but I thought it was getting a little bit too much. But when you actually see this compared to something like the Shingrix vaccine, that's actually increased compared to the COVID-19 vaccine, where there's actually much more side effects in all of these different categories. So in some areas, you're going to see a bit more, but it also differs by age. And the older you are, it seems that you have actually less of these side effects happening. And these are just common side effects that we expect with any vaccine, but you'll just see a slight difference, and it depends which vaccines you look at. So a bit more in some aspects than the flu, but definitely less than Shingrix, which is also another commonly used vaccine.
Thanks so much for that. The next question's from Kara Stern at TVO, and this will be for Dr. Chagla to start. There's a lot of fear and even memes on social media that focus on the 4 people out of 22,000 in the trials who got Bell's palsy after taking the vaccine. Why do you think that's do you think that's why some people may be hesitant, and do you believe that that's an overblown fear?
So first of all, just going back to Dr. Abdurrahman's slide, and I love in the placebo that there's like 33% people that have fatigue, and I think that's a testament to living in 2020 rather than anything else in that sense. But yeah, no, this Bell's palsy issue is certainly described, and it was described in the FDA submission that 4 people got Bell's palsy in the half of 43,000 that got the vaccine. Now, we do have a baseline rate of Bell's palsy, and there's good data even from Canada that it's about 1 in 10,000 per year. And so when you try to add that up, as you go through clinical trials, this is where it gets really complicated to say, is this really causative or is this just the natural rate out there? And when they try to do the statistical analysis, it could fall either within normal or it could fall within a signal towards an issue. It is rare by definition though. And so it could be within what would be considered normal in a given year. Long term, I mean, this is where Dr. Hanna had mentioned that surveillance going forward, that we really do have to monitor this going forward. And this will be an adverse event that's looked for in phase 4 trials. Should it cause hesitation amongst individuals? You know, Bell's palsy, 4 to 5 people recover completely. The rate again is probably very rare in comparison to these clinical trials. And so, you know, I think, you know, we do have to think of this seriously, knowing the magnitude as well of COVID-19. This may be a rare outcome at the worst within COVID-19 vaccine. Again, we can't say yes or no, but knowing the magnitude of outcome of COVID-19, knowing some of the rarer side effects that are happening to young people with COVID-19, like strokes, inflammation of the heart, and sudden death, you know, I think these things just have to be balanced against. If it was me and I'm taking an outcome of potentially a reversible neurologic issue to the face as compared to getting COVID-19, where there's the outcome of death, stroke, heart inflammation, I would probably put my eggs in trying to get the vaccine and prevent myself from getting that other rare outcome on the other side.
Thanks so much. I'm going to ask 2 rapid fire questions, and then that leaves our time. But rest assured, if media have follow-up questions, please reach out and we'll be sure to answer them in short order. The first one is for Dr. Hanna or others. It's related to vaccines and their impacts on pregnancy or folks breastfeeding. Would you provide comment on that, or do you have any insights to share there?
There we go. So the absolute clinical trial data on people that were pregnant or breastfeeding in the clinical trials that received vaccination, they were excluded. So this is where it's real world data, risks, benefits, and having a shared discussion as to what does it mean to get the vaccine and possible side effects or what we may not know, and what does it mean to get COVID and what we have seen. And this is where shared decision making really comes to the forefront. So sometimes when this vaccine or when a vaccine comes into general mass distribution, we don't have data on what happens with pregnancy and what happens with breastfeeding. And that's not an unusual territory. I hate to say it, with a lot of medicine with pregnancy and breastfeeding. We exercise extreme caution, but we always have to risk or balance between risks and benefits, risk of what we know, risk of what we don't know, and come up with a shared decision towards that. And many of the international societies are frankly adopting the same kind of move forward. The more information that we learn, the more that this becomes something that we are more comfortable in offering all pregnant people and all breastfeeding families. But this is, again, the edge of where we know with medicine. I'll pass it on to my colleagues if anyone wants to comment.
Yeah, I can just add that the National Advisory Committee on Immunization has provided a recommendation for these groups to say, just as Dr. Hanna said, that there's a strong recommendation not to provide it just because we don't have studies, but based on that informed consent, the balance of benefits and risks on an individual level, someone who's pregnant or breastfeeding or immune compromised, et cetera, can consider the vaccine.
Great, thanks so much. And Dr. Dubey, while we have you on screen, quickly from Saba Aziz from Global News. So settle it, or if you are vaccinated, is it still possible for you to spread the virus?
Yes, we're waiting to get data on that as well too. So we know that the vaccine is good for, if I get vaccinated, I'm less likely to get a COVID sickness. What we don't know is, does it mean that I won't spread it to others? And so that's some more information that we're going to have to glean based on what's going on in the real world. And so we don't quite know the answer to that yet.
Great. With that, I'll pass it back over to Dr. Hill to provide concluding remarks. Thanks so much.
Thank you, Max. And thank you everyone for being here. Big thanks to our panelists for sharing their time, their expertise, and their wisdom with everyone. And thank you to the reporters for coming in today and hearing what we have to say. As I mentioned earlier, this vaccine is a huge step forward. It really is a bit of a modern miracle, but it's only one of the many steps we have yet to take. We are not out of the woods yet, and a large part of the battle coming up is going to be about effective communication with the general public. And it's so important and so encouraging to me to hear that you are here with your thoughtful and important questions, taking this information and taking it back to your readers. So I hope this information was helpful in informing your reporting. The OMA will be holding more media briefings in the future. If we didn't get a chance to answer your questions due to time, the media team is happy to follow up with you. You can also email media@oma.org with any additional requests for interviews from myself or any of our experts here. I look forward to watching and reading your coverage of the vaccine as your stories roll out. Please do look for a recording of the session on OMA social channels. We're hoping for later today. We'll see whether or not that happens. And on that last note of positivity and optimism, thank you again for your time. Stay safe, stay healthy.